Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Zika virus information for clinicians. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access these materials, but they are available now. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses expiring on March 31st, 2017, and 2 years for social workers, expiring on March 31st, 2018. I'm Dr. Mary McIntyre, Assistant State Health Officer for Disease Control and Prevention and State Epidemiologist at ADPH. And joining me today is Dr. Scott Harris, Assistant State Health Officer for Public Health Area 2, Dr. Karen Landers, Assistant State Health Officer for Public Health Area 1, and Dr. Grace Thomas, Assistant State Health Officer for Family Health Services. Welcome everyone, and let's get started. Today, our objectives are to describe the epidemiology, clinical manifestations, management, and prevention of Zika virus disease, discuss diagnostic testing for Zika virus infection, and articulate the importance of early recognition and the reporting of cases. State the recommendations for pregnant women and others to prevent possible Zika virus exposure, and discuss evaluation of infants with microcephaly and the relationship of Zika and microcephaly. At this time, I will turn it over to Dr. Harris.
Thank you, Dr. McIntyre. We're going to begin talking today about Zika virus, and specifically I want to talk to you a little bit about basic virology. The Zika organism is a single-stranded RNA virus. It's related to the yellow fever virus, and in fact it belongs to a group called flavivirus. The word flavivirus actually comes from the Latin word that means yellow, and so all of these viruses are related somehow to yellow fever, including dengue virus, Japanese encephalitis virus, and the West Nile virus, in addition to Zika. Zika is transmitted to humans primarily by the bite of a certain type of mosquito called the Aedes species of mosquito. And we'll spend a little bit of time now talking about the Aedes mosquitoes. There are actually several different species of Aedes. They're distributed throughout the world, but there are a couple in particular that we want to mention today. Aedes aegypti is perhaps the best known species and one of the ones that's been recognized for a long time to transmit yellow fever as well as dengue and chikungunya. Aedes aegypti has been present in the United States for some time, but now has been largely displaced by what's called the Asian tiger mosquito, which is a cousin of Aedes aegypti, also known as Aedes albopictus. These mosquitoes are extremely common. They tend to live around human households. They live very closely with humans because they feed on humans for a blood meal in order to reproduce. These mosquitoes can reproduce in just about any amount of water. So it's not unusual to find a breeding site in an upturned bottle cap or a discarded soda can or anywhere that you have a small amount of water. These mosquitoes can find a place to reproduce. The dish that sits beneath your pot on the patio in your backyard is a real common place that you might locate these mosquitoes breeding. These mosquitoes tend to bite around dusk and dawn, but they can actually bite anytime. Unlike most mosquitoes, they are daytime biters, but can also bite at night as well. This is a map that you see on your screen that shows you the distribution of where the mosquito can be found. On the left side, you see the area of distribution for Aedes aegypti, and you can see that Alabama is included in that area. This is not surprising since a century or so ago, Alabama frequently had yellow fever transmitted in this area because we certainly had the vector there, and there was enough of a human reservoir of infection that this could be transmitted here in the continental United States. Over the past 25 years or so, Aedes albopictus has largely displaced Aedes aegypti. We don't see Aedes aegypti here very much at all. Most of the Aedes mosquitoes now are albopictus, most if not all, as they've sort of outcompeted the Aedes aegypti species. You can also see that they have a little broader range in which they live. They can live in a little broader range of climates, and you can see geographically they've spread much further north and west than Aedes aegypti ever did. Zika can be transmitted not only from mosquito to humans, but also from mosquito to other non-human primates. So in parts of the world where you have apes or monkeys, you have a sylvatic or jungle cycle of transmission that keeps a reservoir of infection going on even when there aren't any recognized human cases. This is really the case with most flaviviruses in a way, but particularly with Zika. As we'll see a little bit later, Zika was first identified as an illness of monkeys before it finally became an illness that was recognized in humans as well. Besides the mosquito transmission, there certainly are other modes of transmission as well. You'll hear a lot today about maternal-fetal transmission, not only intrauterine, which we hear the most about, but also about the possibility of perinatal transmission. Zika virus has been shown to be sexually transmitted, and you'll hear some more information about that today. There have been reports of Zika virus transmission through blood transfusion and also through laboratory exposure. Because the virus can be transmitted in all those routes, it's certainly reasonable to think that Zika virus could be transmitted through organ transplantation or tissue transplantation, and certainly may be transmitted in breast milk as well. This is a theoretical concern so far. It hasn't been proven to be in breast milk. And at this time, there's no change in recommendations for women to breastfeed. They should continue to do that, even though there is some possibility that Zika virus could be transmitted in that way. This is a map that you can see that shows the current areas of active Zika transmission at the moment. You can see that this involves most of South America, most of Central America, and the Caribbean. There are a few countries that stand out there as not having any Zika virus transmission, but certainly all these countries, such as you see there, Peru and Belize and Cuba, they have the same environments, they have the same mosquito vector. It's just that at this particular time we don't have actual reports of Zika virus transmission, but it would not be surprising to see it in those countries as well. This is a map that's available on the CDC website, and there's a link to this map on the ADPH website, so you can see the most up-to-date country information. It's updated regularly whenever there are new reports of transmission in new countries. Zika was first isolated from a monkey in an area called the Zika forest, which was located in Uganda in Central Africa in the 1940s. Before that, up until recently, that is, there's only been occasional human cases that have been recognized. About 14 cases of human Zika virus were documented before about 2007. It's certainly likely that there are other cases that were around. Zika, by and large, has a fairly has been a fairly mild clinical illness. At least that's what we thought until recently. And it looks similar to many other viral illnesses that can be transmitted in the tropics. And so not a lot was really done to evaluate or try to diagnose Zika virus until recently. In 2007, the first large-scale outbreak was identified in Micronesia, in the Yap Island archipelago, and there were several thousand cases at that time. And then about 4 or 5 years later, in French Polynesia, over 28,000 cases of Zika virus were identified. And that was really the largest scale of outbreak that had been recognized up until that time. In the Americas, we really had not seen Zika virus to speak of until finally in May 2015, the first locally acquired cases were reported in Brazil. And as you know, that's what's really spurred the current interest in Zika virus. In 2014, just a year before, the World Cup soccer tournament was in Brazil, and there were literally millions of people traveling from all over the world, including other Zika endemic places. And so it's possible that there's some way that this could have been brought at that time. The truth is nobody really knows that, but it's certainly a possibility. But just almost a year ago is when the first locally acquired cases were first reported, and now it's sort of changed into the epidemic that we have now. Currently, we have outbreaks occurring in many different countries or territories throughout the Western Hemisphere, including Puerto Rico, including the U.S. Virgin Islands. As I mentioned earlier, it's likely to continue spreading through other countries, particularly in tropical areas, because they have the same environment, the same vector, and because of the way that people travel, now we have a human reservoir of disease too that allows transmission to occur. Local transmission or mosquito-based transmission has not been reported in the continental United States. As we mentioned, there has been some in Puerto Rico or the U.S. Virgin Islands, but not in the lower 48 states. There have been some laboratory-confirmed Zika cases in patients who were travelers since about 2011, and then recently we've started to see increased numbers of this as well. The most up-to-date statistics I have here are from a couple of weeks ago, and as of February 24th of this year, about 107 travel-associated cases have been reported to the CDC, as well as some from U.S. territories, including locally acquired cases, primarily in Puerto Rico. We expect, because of the outbreaks going on in the Americas, that we're going to see increasing cases. Imported cases may result in the virus being introduced and spread here locally. We don't really know how much virus we expect to see here, but it's certainly reasonable to expect that we will see some. We have the vector here, as we mentioned, and once we have a reservoir of people who are carrying the virus, then possibly some local transmission will occur. Obviously, at ADPH, one of our goals is try to prevent that. We want to make sure that doesn't happen, but it certainly would not be surprising to see some locally acquired disease transmitted by mosquitoes. Okay. The infection rate of Zika virus is actually quite significant. It's about 3/4 of people who are at risk and are exposed to the virus do become infected. Interestingly, though, only about 1 in 5 people know that they're infected. Most people remain asymptomatic and don't know that they're infected unless they have blood work to show that. All age groups are infected. Adults are more likely to present for medical care, but children can certainly be infected as well. Pregnant women is something we'll talk about a great deal today. They don't appear to be more susceptible to being infected, but they certainly can be infected like anyone else. By and large, we don't see severe disease or hospitalizations or deaths related to Zika virus, but there are a couple of exceptions that we'll talk about. Generally speaking, the symptoms are fairly nonspecific. Rash is the most commonly reported sign that was seen in this particular study. Fever, joint pain, and conjunctivitis are also fairly common, and those are some of the things that are used in the clinical case definition of the disease. Conjunctivitis in particular is one that's much more common with Zika virus than with some of the other arboviral diseases. But you see the list there. There's several different things there that can look like other types of infections and are really fairly nonspecific. Clinical illness is usually mild. People tend to stay sick for a few days or a week or so. Severe disease is uncommon, and as we mentioned, about 80% of people do not even realize that they've been infected. There is one medical complication that I want to mention at this time. There has been an association seen, at least statistically, with Zika virus infection and Guillain-Barré syndrome. It's not really clear what the association actually is, but in some countries, first in Brazil and now retrospectively looking at the Zika epidemics that were in French Polynesia and in the Yap Islands, there has been an increase in Guillain-Barré cases in people that were infected with Zika. Most recently, the Brazil Ministry of Health has reported an increased number of people with Guillain-Barré syndrome, and the CDC is working with Brazil to sort of study the possibility of a link there. Guillain-Barré is not a particularly common disorder, but it is an autoimmune polyneuropathy in which people typically develop muscle weakness or paralysis. It's classically described as an ascending paralysis. It starts distally, but it can actually start anywhere in the body. It tends to be symmetric. Guillain-Barré is actually sort of it's a constellation of diseases. There's not one type of Guillain-Barré, but probably several illnesses that mimic, that have the same symptoms that involve polyneuropathy. But this particular type has been seen, as I mentioned, with Zika virus. Most people tend to recover from this. A few people have permanent damage. Occasionally people do die from Guillain-Barré, typically from respiratory failure, although most people do not. Infection has really long been associated with Guillain-Barré, infection of many types. It seems to be an autoimmune reaction that happens after infection of some kind. The most commonly reported infection is Campylobacter infection, which can result in Guillain-Barré, but it's been associated with many other things, including Epstein-Barr virus, even HIV infection. Patients with all of those infections have increased rates of Guillain-Barré. And then perhaps one of the more famous episodes was the association of the swine flu vaccine in the 1970s with Guillain-Barré as well. I do want to mention something about distinguishing Zika from Dengue and from Chikungunya. Because these viruses occur in similar parts of the world, typically in the tropics, and because they have the same mosquito vector, and because they have a lot of the same symptoms and signs, they're very difficult to distinguish clinically. They really look alike, and in fact, co-infections can actually occur, so it's possible for someone to have more than one of these diseases at the same time. It's actually very important to rule out dengue and chikungunya when you are evaluating somebody with Zika, and you'll hear more about testing from Dr. McIntyre about that in just a little bit. This is just a little chart that sort of shows you the clinical features of these three arboviral diseases. You can see, first of all, that they have a lot of overlap. They all have fever. They all have some degree of rash. Conjunctivitis is more common with Zika virus, as I mentioned. People with chikungunya, sort of famously have arthralgia, which can be very long-lasting. So there are a few distinguishing characteristics, but the main lesson is that these are very difficult to tell apart in a clinical way, and that's why testing is necessary to be able to distinguish between them. Okay. Finally, I just want to show you the patient information fact sheet that ADPH has come up with. This is something that can be provided to your patients if they need to be tested for Zika. This is available on the website, has a lot of good information there, and explains exactly why a test is being done and why you as a clinician need to have the patient tested to determine whether Zika is present. At this time, I'm going to turn it back over to Dr. McIntyre to talk to us about testing.
Thank you, Scott. I'm going to actually go into the diagnostic pieces and the guidance that is available, and I'm going to remind everyone again, this information is available on the website. We also will have the on-demand presentation from this video available probably in the next 2 days, where you'll be able to access the full video. When we look at diagnostic testing for Zika virus, we look basically at what we look at acute disease phase, and we look at those people that fall beyond that and the ones potentially that are asymptomatic. Currently, what we actually do as far as recommendations for testing is we test any person that is symptomatic with a travel history to a Zika-affected area who develops symptoms either during travel or within 2 weeks of travel. That's men, women, children, symptomatic. Anyone, for pregnant women, you're going to get additional information on that, and it varies a little bit because they can be asymptomatic and be tested. So the initial testing done when someone is in the acute phase with symptoms, and they come in and they say, well, our onset of symptoms occurred a day ago, 2 days ago, is the test called the reverse transcriptase polymerase chain reaction, which is a PCR test. When we have people that are beyond that time frame, usually greater than 4 days, there's an additional test that looks at the appearance or the development of antibodies, and it's also a serology test, and it's checking for IgM antibody, the presence of it. Based on whether that test is positive or not, there's an additional test that may be done. It's called PRINT, which is a neutralizing antibody test. All of these tests currently have to be done at the CDC. We are working, when I say we, ADPH and our state lab are working to get the capacity and the ability to be able to do this testing. We currently do not have that capacity. CDC is pushing out and trying to increase the availability of testing as quick as they can. So hopefully we will have that ability within the next month or so. There is an ability to be able to do immunohistochemical staining for viral antigens, and this is usually with tissue. You will get some more details with that as part of the infant discussion and also with the pregnancy discussion. Serology cross-reactions do occur with other flaviviruses. Sometimes it's really difficult to distinguish based on the test results what the results mean, which is why it's extremely important that we consult with physicians. It is a requirement for any testing to be submitted to BCL for submission to CDC that a consultation is completed, which means that we need the information on that person so that we can approve testing. We have received some requests for people who haven't even traveled to a Zika affected area. Those requests have been denied and will continue to be denied because there's no indication of local transmission at this time. Now, you will hear a little bit about sexual transmission, and we do ask questions about that to identify if there's any potential, and if we identify that, that person will be approved for testing. So when we look specifically at the cross-reactivity with the other flaviviruses, it becomes difficult unless there's a fourfold or greater difference between the dengue or the chikungunya that may be positive and the Zika. So we're looking at Zika being at least fourfold greater when we look at the antibodies to tell whether or not it's actually a Zika infection. We have had at least one flavivirus unspecified. What that means is that we know the person had exposure to recent infection with a flavivirus, but we can't differentiate which type. We don't know whether it's Zika. We don't know whether it is dengue. We were able to rule out, or CDC was Chikungunya, but that means that it could be either of those infections or a combination of them or another flavivirus. So when we look at the testing currently, as we've indicated, CDC is actually doing it. We are also doing some to actually do validation testing at the state lab to get the capacity to be able to do the testing. We say no commercially available. There are people that have come out with some tests, but they're not FDA approved yet, and we're not recommending that people use them, and neither is the CDC. Testing performed at the CDC now and a few state health departments, and hopefully soon at ADPH. We must be contacted for approval of the diagnostic testing. This is guidance that is actually available, and we send it anytime we get a consultation or request for review that explains specifically what has to be done in order to make sure that the specimen that's received by the state lab is valid, so that that is not unsatisfactory. And there are several things that have been occurring that I'm going to talk about it near the end of this. But to request this, for a specimen to be tested, go ahead and make a request to the IDNO, and basically what happens then is those nurses will then send out the consultation form. You have to collect blood specimens in a Tiger-top tube, which is a separator tube, centrifuge, extract the serum, and place in a sterile tube. It must be kept refrigerated until it's shipped, and when it's shipped, it needs to be shipped on ice. It needs to be kept cold. Collect 2 to 3 millimeters of urine within 7 days of illness, and this is only for that acute phase. We don't do it when somebody is 2 weeks out or more than a week out. In a sterile container and seal it with parafilm. The urine should be kept refrigerated again. It needs to be kept cold and not submitted without being on ice. Now, the serum, never send us a urine specimen without sending a serum specimen. And complete one BCL requisition form and submit it with the specimen to BCL. Select arboviral testing and indicate Zika, dengue, and chikungunya as the agent suspected. And the reason for this is that if we're doing Zika testing, the recommendation is to also make sure that dengue and chikungunya are also being tested for. Because as Dr. Harris already explained to you, these are very similar as far as how they present. And one of the things with dengue is that it needs to be ruled out because it can be really significant in the problems that that can occur, including one of the symptoms that was checked was hemorrhage, which is that can be an issue. So when you have to complete one CDC specimen submission form. And I'm going to repeat it again. This information is also available on our website. Include the specimen collection date, the date of symptom onset, as well as the dates and locations of recent travel and relevant vaccine history. We've received information about countries, but not necessarily about where they were in those countries. And some of the people that we're receiving requests for have actually traveled to multiple countries. We need to know that. Specimen origin, top left corner on that form needs to be marked as human. Test order name, arbovirus serology. And note that Zika virus testing is not an option in the suspected down menu that's located on the first page. What you have to do is actually either type in or write in arbovirus serology and then you select arbovirus serology and then write in or type Zika virus testing in the section that says brief clinical summary. This has been an issue with some of the specimens that have been submitted. And these instructions are also available on CDC's website. Click the following link to print the completed form. Instructions will also enable printing of CDC submission form, which is what we have to use in order to get the specimen submitted. So this information is available at the link. The specimen should be kept cold, not frozen. The specimen should be placed in an insulated container with ice packs for shipping. If it is received warm, it will be unsetted, which means it's unsatisfactory for testing, and that creates a problem, especially if the patient is now outside of that 7-day window that we're trying to get a acute specimen for, or even to the standpoint of when we're actually trying to do convalescent serum testing to try to see if there's been a change in the antibody titer. The outer container must be labeled as UN 3373, biological substance category B. You can take the specimen to the local county health department and it'll be carried to BCL at no cost, which means you don't have to pay for shipping. You can contact your local county health department to coordinate carrier pickup. Someone will get the specimen and get it so that it actually can be transported to BCL. Or there's always the option for it to be shipped directly to BCL as long as all of the requirements that I just went over are met, okay? If that happens, then that submission is at the person that's actually doing that will have to pay in order to get it shipped. Now, what are the most common errors? This is something the lab wanted us to make sure that we talked about. Some of the most common reasons for the specimen being unsatisfactory, which means it cannot be submitted to CDC for testing or used for testing by the state lab for validation purposes. No ice. What happens is it means that the specimen is received warm, so this affects the integrity of the specimen, so we cannot use it. No labels. Category B packing instructions must be followed. It's a regulatory requirement, and the CDC and the state requires it. If that happens, then we've got an issue and a problem with contents. And no consultation. People are sending actually specimens to the state lab that no one even knows that they're going to arrive. There's been no consultation or call made to the infectious diseases in the outbreaks area. And it just shows up, the lab contacts us, and then what we're having to do is try to backtrack to figure out, is this even one that will be approved and acceptable for testing? So I'm going to turn it back over now to Dr. Harris.
Thank you, Mary. I just want to say just a few more words about assessment and treatment of Zika. There is no specific antiviral therapy for Zika, which is true for a lot, if not most, viral diseases. Treatment is going to be supportive, so bed rest and fluids and hydration, pain relief, treatment for fever when it's present. Those are the normal symptomatic treatments that should be provided. As we have mentioned today, it is very difficult to tell the difference between Zika and other arboviral infections, and so as Mary mentioned, we're particularly concerned that someone could have dengue and not be recognized as well. So for that reason, aspirin or NSAIDs should be avoided in these patients to treat them for pain or fever. Dengue, as was mentioned, can produce thrombocytopenia or coagulopathy. There's a hemorrhagic fever form of dengue that has significant bleeding risk, and so you certainly don't want to use aspirin or NSAIDs in these patients until dengue has been ruled out. We would ask you to help us with the surveillance of people who may be at risk for this. So if you have a person who presents with acute symptoms, someone who's been in a Zika-affected area within the last 2 weeks who presents with fever, rash, joint pain, or conjunctivitis, then we certainly would want that person to be tested for Zika, even though there's no specific treatment or therapy for Zika. Even if it's a person who's a male or a non-pregnant person for whom you're not worried about severe complications, we would certainly still want to have that patient tested so that we can monitor that. For women who have been to Zika-affected areas while they were pregnant, you certainly would want to evaluate them as well, inform them, and discuss testing with them as well. For women who have been infected during pregnancy or may have been infected during pregnancy, then there's certainly a concern about the possibility of congenital infection, and so the fetus or the newborn would need to be evaluated for the possibility of microcephaly, and you'll hear more about that in just a moment. Finally, I'll just remind you that Zika is an arboviral disease, and so it is nationally notifiable, so we certainly want to be aware of that if you know or suspect of that. There's a phone number on the screen that you can see there. If you know of or suspect of a case of any arboviral disease, then please notify us at the IDNO division, the Infectious Disease and Outbreak Division, because we'd like to be aware of that. Timely reporting allows health departments to assess and reduce the risk of local transmission. If we have a reservoir of humans with this disease living in our state, we certainly would want to know that. It's not mosquito season yet, but it's just about to be, so certainly we want to be aware of any potential cases of Zika here in Alabama. Okay. Finally, I'll say there is no vaccine or medication to prevent it at this time. The primary way to prevent this disease is to reduce mosquito exposure. For people traveling to areas of Zika transmission, then that means dressing appropriately, using appropriate insect repellent, avoiding areas or times of day when mosquito bites are likely to be present. There is a recommendation that pregnant women should consider postponing their travel to areas where there's an ongoing Zika virus outbreak, and we would encourage you to discuss that with your patients who are pregnant and are considering travel. During the first week or so of acute infection, is when people seem to be the most viremic. They seem to have the most virus in their blood, and so during that particular time, they should take special care to avoid mosquito bites so that there is no further local transmission from them to other folks in their household or in their area. Okay, and now I'm going to turn it over to Dr. Grace Thomas, who's going to talk to you about Zika virus and pregnancy.
Thank you, Dr. Harris. The role Zika virus will play in pregnancy requires evolving care and practice. Though this virus has been around for more than half a century, today there are more unknowns than knowns about Zika virus as physicians and clinicians across the country grapple to better understand the illness associated with Zika virus, its sequelae, and exactly what to say to patients. So it's important to stay abreast as we get closer to the peak season and hot weather and humidity, the type of environment that this virus thrives on. Existing data show pregnant women are not known to have increased susceptibility to Zika virus when compared with the general population. Infection, as you heard earlier, can occur in any trimester, and maternal fetal transmission of the virus can occur throughout pregnancy. Vertical transmission can also occur from mom to baby at the time of delivery. There is no evidence to suggest pregnant women will have a more serious illness if infected. As with any demographic, the illness is short-lived, occurring 2 to 12 days following the mosquito bite. Infected individuals usually do not require hospitalization or experience serious morbidity. There is no antiviral treatment, no prophylactic medication or vaccination for Zika virus. Because of the virus's significant association with adverse pregnancy outcomes, birth defects, and fetal loss, the recommendation currently is to avoid travel to Zika-affected areas. As you heard earlier, outbreaks are occurring throughout South and Central America, the Pacific Islands, and Africa, and are expected to spread with international air travel. The initial recommendation from the CDC for pregnant women in any trimester was to consider postponing travel to areas where Zika is present. That has since been updated to state that women should avoid travel to these areas altogether. The CDC has also recently revised or modified its travel notices to state that pregnant women may safely travel to Zika-infected areas that are 6,500 feet in altitude, where the Zika virus, and this is because the Zika virus is not going to live or survive at this altitude, or is rarely found at this altitude. If travel to these areas is inevitable, pregnant women should talk to their healthcare providers and take rigorous precautions to avoid exposure to mosquito bites and infection. Pregnant women who have a male partner who has traveled to a Zika-affected area should ask their partners to consistently and correctly use condoms or consider abstaining from insertive sexual activity for the duration of the pregnancy. When evaluating pregnant travelers, ask about their travel history. If history of travel to an area with ongoing Zika virus has occurred during the pregnancy, these patients should be evaluated for symptoms and tested for the Zika virus. Antibody testing for Zika virus is now recommended for all pregnant women who have traveled to an affected area, regardless of the presence of clinical illness. Testing is recommended for pregnant women with clinical illness, that is, the presence of 2 or more of the following symptoms, common symptoms, such as acute onset of fever, maculopapular rash, arthralgia, or conjunctivitis during or within 2 weeks of travel to a Zika-affected area. Testing can be performed to pregnant asymptomatic women as well with a travel history to a Zika-affected area. The IgM antibody testing in this particular scenario of the asymptomatic woman should be performed 2 to 12 weeks after return from travel. And as was mentioned earlier by Dr. Harris, 80% of patients infected with Zika virus remain asymptomatic. In terms of diagnostic tests, this was mentioned previously, the laboratory evidence of maternal Zika virus infection can include the Zika virus RNA, which is detected by reverse transcriptase PCR in any clinical specimen. A positive Zika virus IgM will need to be confirmed, and this is done by the plaque reduction neutralizing test. And this is going to need to be confirmed, and it's confirmed when the neutralizing antibody of the Zika virus is 4 times higher than that of the dengue virus neutralizing antibody titers. Testing would be considered inconclusive if the Zika virus neutralizing antibodies are 4-fold less than the dengue virus neutralizing antibodies. The best diagnostic test for infection is reverse transcriptase PCR, which should be completed ideally within 4 days of symptom onset. Beyond 4 days of symptom onset, testing for Zika virus IgM-specific antibody and the neutralizing antibody should be performed in addition to the reverse transcriptase test. This table summarizes what was said in the last 3 slides, again about testing for Zika virus following symptom onset. In an asymptomatic patient, a negative IgM test result obtained 2 to 12 weeks after travel suggests that a recent infection did not occur and could obviate the need for serial ultrasounds. As mentioned earlier, interpretation of antibody testing can be problematic because of cross-reactivity with related arboviruses, or if patients have had a previous arbovirus infection or have been vaccinated for one of the arboviruses. Zika viremia decreases rapidly over time. Therefore, if serum is collected even 5 to 7 days after onset, a negative test does not definitively exclude infection. The CDC recommends offering retesting in mid-second trimester for women who were exposed very early in gestation. Testing is not indicated for women without a history of travel to areas where Zika virus infection is endemic or without a history of unprotected sexual contact with someone who has been exposed to the infection. This schematic shows any pregnant woman with a history of travel to an infected, to an area where the Zika virus transmission is occurring. If you look to the left of the chart, of the schematic, if this test is positive or inconclusive for Zika virus infection, the consideration for serial fetal ultrasounds should be considered along with amniocentesis for Zika virus testing, and this should be done in consultation with a maternal fetal medicine specialist. If a patient tests negative for the Zika virus infection, the fetal ultrasound to detect microcephaly or intracranial calcifications should be done, and if microcephaly or intracranial calcifications are present, the patient should be retested for the Zika virus and amniocentesis should be considered. This is a case presentation of a pregnant patient at an estimated gestational age of 26 weeks with a history of travel to Colombia on March the 1st through March 8th. She has noted bites, fever, and a rash. So this is your symptomatic patient. If your patient has a history of travel to a Zika virus-affected area and presents with signs of an acute infection within 2 weeks of travel, serologic testing is needed. Clinical illness consistent with Zika virus disease is defined by the CDC as 2 or more of the following common signs or symptoms: acute onset of fever, maculopapular rash, arthralgia, and conjunctivitis. If the serologic testing is positive or inconclusive, or ultrasound findings are consistent with Zika virus infection, amniocentesis with reverse transcriptase PCR test for Zika virus should be considered. In this second case of an asymptomatic patient who presents at an estimated gestational age of 20 weeks with a history of travel to Mexico between the gestational ages of 16 and a half weeks. She has noted mosquito bites but no illness. In an asymptomatic patient with a history of travel to an endemic area, serum IgM assay is now recommended between 2 and 12 weeks after exposure. If the IgM result is positive or inconclusive, serial fetal ultrasound to screen for microcephaly and intracranial calcifications should be performed. The treatment, as mentioned earlier, for Zika virus is supportive. It includes rest, fluids, with analgesics and antipyretics. Aspirin should be avoided until dengue virus infection can be ruled out because of the related risk of bleeding with hemorrhagic fever. Pregnant women with fever should be treated with acetaminophen, and NSAIDs should be avoided in the second half of pregnancy because of their effect on the fetal renal blood flow and the structure of the ductus arteriosus. It's important for clinicians to be aware that the fetal ultrasound may not detect microcephaly or calcifications until late in the second trimester or early third trimester. If markers are concerning for fetal infection, amniocentesis with reversed transcriptase PCR testing should be considered. The sensitivity and specificity of RT-PCR on amniotic fluid is unknown, and maternal fetal transmission risks from an invasive procedure like amniocentesis are unknown. Even if the IgM is negative, a baseline screening ultrasound should be performed. If the patient is negative for both serologic testing and ultrasound findings, the patient can resume routine prenatal care. This is a decision that should be made in consultation with a maternal fetal medicine specialist. Postpartum, the Zika virus RNA has been detected in blood, amniotic fluid, semen, saliva, CSF, urine, and breast milk. A detailed histologic examination of the placenta and umbilical cord should ensue, testing of frozen placental tissue and cord tissue for Zika virus RNA, as well as the cord serum for Zika and dengue virus IgM and neutralizing antibodies. Although the virus has been shown to be present in breast milk, there has been no evidence of viral replication in milk or reported transmission in breastfed infants. So the recommendation is still to breastfeed in these settings. Zika virus infection has been confirmed in infants with microcephaly in Brazil, as mentioned previously, and in infants whose mothers have traveled to Brazil and delivered in the U.S. Reports of a substantial uptick in the number of babies born with microcephaly in 2015 has occurred in Brazil. Between the 2010 and 2014, Brazil had 163 cases per year of microcephaly. From 2015 to present, the number of cases recorded is over 4,000. Zika virus infection has been identified in several infants born with microcephaly and in early fetal losses. To avoid mosquito bites, EPA-registered repellents, including DEET, are considered safe to use in pregnant and lactating women. Wear long-sleeve shirts and long pants to cover exposed skin, and wear permethrin-treated clothes. Of note, recent reports state that the Aedes aegypti mosquito has developed resistance to permethrin in Puerto Rico as well as parts of Mexico. Pregnant women should stay and sleep in screened-in or air-conditioned rooms and practice mosquito prevention strategies throughout the entire day. Women of reproductive age with current or previous laboratory-confirmed Zika virus infection should be counseled that there is no evidence that prior Zika virus infection poses a risk of birth defects in future pregnancies. This is because viremia is expected to last approximately 1 week in patients with clinical illness. The CDC has recently established a national registry to learn more about the risk of Zika virus during pregnancy, and hopefully this knowledge gained will be used to assist in responding to the ongoing outbreaks. I will now turn it over to Dr. Harris.
Is it me? That's you.
Yes. I'm going to actually talk about the Zika virus and sexual transmission, and I'm going to actually skip through some of the slides because some of this is already been covered, so I don't want you to have to go through and listen to a repeat of it. But I am sure that you've seen the information that the CDC actually had a provider called a few weeks ago and talked about the presence of and evidence of sexual transmission having occurred within the United States, and specifically about the fact that these people actually had not traveled out of the country, which is why it was known that there was sexual transmission. One of the problems prior to this with the countries in when we know, like in Brazil where there is local transmission, is really hard to actually figure out whether it was the infection occurred because of a mosquito bite versus it was transferred from someone and given to someone by sexual intercourse. Here, because these specific folks, and we don't have local transmission, we had a better chance and an opportunity to be able, from an epidemiological standpoint and clinically, to identify that it was they were infected by sexual transmission. I'm going through these because they talk about the first, second, and third, and we're now way past that as far as the numbers. There is evidence that the Zika virus can be sexually transmitted by a man to his sex partners. As of February the 24th, 14 cases of sexually transmitted Zika virus has been reported. There was actually a media conference, and CDC reported this information, and they talked about from the very beginning the need for consistent and correct condom use, even before the evidence of these 14 cases occurred, which means that we're really encouraging providers to talk to their patients about how important it is for this to be done, especially for partners of pregnant women. How long, what we don't know. How long is the, well, let me go back. So what do we know? We do know that it is sexually transmitted. At one point, there was some question on how frequently that occurred. Well, we now know that it occurs more frequently than was initially thought. It's present in semen longer than in blood. We know that. But how much longer? Currently, right now, there have been only a few people where there actually had testing done, and it was present in one person as long out at the time that they were tested at 60 days. So this is why the recommendation is for the use of the condoms throughout the pregnancy until the baby is delivered, because there is no end time as far as saying 3 months out, 4 months out, they're no longer infected. This is still information that we don't know. So what don't we know? How long it's present, and if infected men who never develop symptoms can actually have the virus and transmit it. The cases of sexual transmission that have occurred in the United States, and even prior to that with the initial two, they all occurred in people that were symptomatic, men that had symptoms of infection when they actually transmitted this virus. But we don't know if an asymptomatic man can transmit it. If the infected men who develop it can actually do that, we've talked about it, who never developed the symptoms, and if a woman can transmit Zika, we don't know that. We haven't identified it, but that doesn't mean that it can occur. At this time, there is no evidence that women can transmit it to their sex partners, and while there are tests that are available to detect Zika virus in the semen, they are not widely available. And the other thing that we don't know, even if testing, we've had requests for people to do serum testing on people. There's no recommendation by the CDC or anyone else to test asymptomatic men from a serology standpoint. So that is not one of the things that we're doing. So when we receive a request for testing on a man without any symptoms, the test will be denied as far as the consultation standpoint. Part of this is because it's so difficult to actually interpret what the results mean currently within the population that we're doing the test in. And in this population, even getting results, it will really be difficult to understand what they mean. In addition, most clinicians, because it's really difficult, we've even had to get consultations with the arbovirus people at the CDC to make sure that we're interpreting the results of the test correctly when we get results back. So what are the recommendations for men who traveled to a Zika-affected area? If the man's partner is pregnant, the couple should either not have sex or use condoms the right way every time. They have either vaginal, anal, or oral sex during the partner's pregnancy, the entire pregnancy. Condoms can also help prevent getting HIV and other sexually transmitted diseases. Men who live in or traveling in an area should take steps to prevent mosquito bites. And this isn't just for men, this is for everyone. Men, women, and children. If you're going to be traveling, whether pregnant or not, please protect yourself against mosquito bites. And this is a recommendation you should be making with your patients. If a man develops symptoms of Zika virus illness at any time during his travel or within 2 weeks of returning, he should see the healthcare provider, and it is recommended that the healthcare provider contact us because we are testing people with symptoms and the travel history. Not having sex, as we all know, is the best way to be sure that someone does not get the virus. So that is ultimately the recommendation, and we do have a male patient information handout available on our website with this information. At this time, Dr. Landers is going to talk to you about the Zika virus in infants and children.
Thank you very much, and I will try not to drop the microphone as I did a few moments ago, in case you wondered what happened there. That was me. Okay, well, I think to kind of wrap up today, the most important aspect in talking about the Zika virus in terms of the ultimate outcome with infants and children is the devastating effect that this can have on infants and children. And again, you have to remember that obviously if the mother's infected in pregnancy, the child develops the microcephaly. I mean, as much as we can do in terms of evaluation for the microcephaly, we really cannot treat or cure that. So again, prevention is the word that we have to use with our patients. When we're talking about microcephaly, we have to look at microcephaly in terms of really a sign. It's not a diagnosis. It is a clinical finding. And again, looking at definitions for this, one thing we have to remember, several definitions. One is having a head that is more than 2 standard deviations less than the mean for age, gender, and conceptual age. I mean, obviously, you know, we have premature infants, and we have to look at that also. In addition, another definition is looking at head circumference that is less than the 3rd percentile. So there's several definitions in standard textbooks, such as Nelson's Pediatrics, that provide you the information on microcephaly. Another thing that we have to consider in looking at microcephaly as a sign is we have to get a correct head measurement. Again, if a child has extreme small head, that's not quite as difficult, but if it's kind of a borderline situation, or in this particular situation, we want to measure the head using the occipitofrontal circumference, and this is really better done not at the time of birth, but after a couple of days, because you can see some molding of the head. So we want to make sure that we have proper head measurement. And again, for pediatricians, you know, I would just urge that we continue to work with our nurses and our other colleagues to ensure that the head circumference is done correctly. You know, the most prominent part of the occiput and about 1 inch above the brow with the measuring tape. So just be sure you measure correctly, because I think it's extremely important here to have this information. Now again, microcephaly is a reliable assessment of the intracranial volume, and we all know that microcephaly in and of itself with the other associated findings can lead to devastating problems in the child, global developmental delay, seizures, all kinds of issues that again we can treat in a manner, but we certainly cannot cure this problem. And again, when we look at microcephaly, it's probably helpful to define it in the primary microcephaly, which, you know, can be seen in genetic etiologies. You know, for example, some of the trisomy 18, you can see a microcephaly. In addition to that, what we're looking at here is a secondary microcephaly, also with the brain tissue having infection and vascular disruption. Again, other etiologies for this, other congenital infections can cause this. And again, as I mentioned earlier, inconsistency of the definition. So it's exquisitely important as we are evaluating infants for microcephaly that we correctly measure and correctly document that so that we can follow that information. There's just a few pictures that I think you see. Obviously, the first picture here is a normal appearing head, and then a moderate and quite severe microcephaly there. So what do we know about Zika? Well, obviously we know some, but we certainly need to know more. As has been mentioned earlier, we had a small number of test results for Zika positive in infants with microcephaly in the literature in the last couple of years, and this was consistent with mothers that had had Zika virus infections. The investigation from French Polynesia, I just read yesterday in some information that they only have one fetal maternal center there, so it's really a good place for them to get all of the information, as opposed to a country such as Brazil, which has obviously a lot more patients and a lot more providers, and I think that, again, it makes this particular study somewhat useful. Although there was some discussion about, well, what is the real incidence here? Well, we really don't know, so I would caution just looking at one study saying, okay, this is the incidence. We certainly have to look at microcephaly with some of the more common etiologies that we see, again, such as cytomegalovirus, and we've known about that for a long time. Well, what we do not know, okay, we don't absolutely have that causal relationship here. What we have is the clinical information so far, some information from literature, but we really don't have that absolute link, and we don't have that clear indication of, okay, this woman has a Zika infection. What is the risk of her having a child with microcephaly? And all of us can relate to the difficulty that this would cause a woman and her partner during pregnancy and at the time of delivery, and of course the extreme level of pediatric care that would be needed. And again, when we're talking about the Zika virus laboratory testing for infants, I'm going to spend a little time on an algorithm which is available as part of this presentation in a full-size algorithm, so that you can look at this and follow this if you are needing to evaluate an infant in this particular situation. Again, infants with microcephaly or intracranial calcification, and I think those are really the two things we need to look at: microcephaly or intracranial calcifications. And intracranial calcifications, they certainly can occur together. Born to women who have traveled or resided in an area that Zika transmission is known to be occurring, or infants also born to mothers with positive or inconclusive tests for Zika virus. Okay, and what testing is recommended? Well, again, as Dr. Mack, Dr. Harrison, and also Dr. Thomas have mentioned, we're using the Zika virus RNA testing, the IgM, the neutralizing antibodies, the dengue. We're going to test these particular infants. We're going to cast a wide net with the testing to ensure that we have correct data. Again, clinical specimens, I think this is extremely important, and one of the most compelling pieces of information as I was looking at what we do know about this is that doing a serum specimen, certainly from the umbilical cord. Again, being a pediatrician myself, it's a nice place to get blood as opposed to having to draw blood from a kid a couple of days later. I mean, it obviously can be done, but if you can get it from the cord, that's a really good place to get a good volume of blood. And if CSF is obtained, and again, depending on the clinical assessment of that child, if CSF is being obtained for other studies, then certainly, that specimen would be useful for our Zika testing. And again, also placental studies. I think this is extremely important, and this is going to ultimately provide us more information as we assess infants that are born to mothers who have positive or inconclusive Zika testing. So again, if the mother has not already been tested, obviously if we have a child that's born to a mother that's been in a Zika endemic area and perhaps testing was not done, then we'll go ahead and do the testing for Zika, but also for dengue. Now again, here is the algorithm, and I'll try not to turn anything over as we're looking at this. If we can zoom in on that. First of all, we want to look at infants whose mothers have traveled or resided in an area where Zika has been transmitted. Okay? Then, do these infants, as I mentioned earlier, have microcephaly or intracranial calcifications detected? Okay? If they do, then we're obviously going to conduct a thorough physical examination. And this particular algorithm refers to box 1, and that's actually from the February the 26th, 2016 MMWR, which provides additional information on the clinical assessment. Moving down, we assess the infant, we do testing. Is it positive or inconclusive? Well, again, I don't like inconclusive, so I hope it's either positive or negative. It makes it easier for me. We will perform additional clinical evaluation, and I will discuss that momentarily regarding what testing. If it is negative, which obviously is a good outcome here, then we would evaluate if this child had microcephaly and or intracranial calcifications. We would look for other etiologies of that. You know, as I mentioned earlier, you know, other reasons a child can have microcephaly. You know, one, CMV. Obviously, we need to think about other reasons such as even syphilis or herpes or something of that nature. Okay, well, let's say, for example, we have the child that has no microcephaly or intracranial calcifications at birth, but, you know, we tested the mother. The mother had a positive or inconclusive Zika virus test. Well, same thing. Obviously, we're going to completely evaluate that child in terms of physical examination, see if we have any findings there, and then go ahead and test for the infant for Zika. And depending on what that shows, then we will go on to further additional testing, or if we have negative testing, then routine infant care and appropriate follow-up. Again, we're not absolutely ruling out everything here just based upon one or two tests, but this does help us if the testing on the mother is positive or inconclusive and the infant is negative. That really does help us in terms of hoping that we don't have an infant that is exposed and has the Zika virus infection. Okay, so again, for all infants with a possible congenital Zika virus infection, we're clearly going to do a thorough physical examination. I can't stress the head circumference enough, as well as other parameters of growth assessment for gestational age. And obviously, the cranial ultrasound would be useful unless the prenatal ultrasound from the last trimester of pregnancy showed the abnormalities that we were concerned about. We can certainly do either OAE or ABR depending on which testing method is available. And again, we're doing hearing testing here in children in Alabama anyway at the time of discharge from the hospital, and that's useful. And then follow up within a month after birth. But again, I think it's very important that we're also doing hearing testing here as part of our routine newborn screening in infants. Eye examination, this should certainly be done as part of our complete evaluation, and certainly within a reasonable period of time after evaluation. And if abnormalities are noted, and I think in a situation such as this, you're going to have many subspecialists involved in the assessment, and this kind of examination really best being done by a pediatric ophthalmologist to have the capability to assess for those findings. Again, a child with microcephaly, as we are waiting for this evaluation, waiting for blood testing to get back, depending on the information that we receive, we would involve multiple subspecialists because we would want to be assessing with a neurologist for other tests that might need to be done, including an EEG, MRI, etc. Infectious disease specialists can certainly be very useful and will be useful as we are assessing these infants, because we are considering not only Zika virus as an etiology for this, but also looking at other congenital infections that could lead to a microcephalic picture. And finally, other routine blood testing that can be done, CBC platelet counts, liver functions, just the things that we normally would do in a thorough assessment of a child in this particular situation, as well as genetic testing and other teratogenic testing depending on the clinical picture. Now again, when we're talking about following these cases, if we have children that have positive testing for Zika, well obviously we're going to be following these kids. I mean, this needs to be reported to the state, territorial or local health department, because these children will need to be followed for a long period of time with multiple avenues of care to ensure the outcome where we can intervene with whatever methods. Again, if this is a child that is microcephalic, they're going to require a lot of developmental evaluation and assessment. If they need hearing aids, I mean, there are just so many visual assistance. There's so many factors that we need to consider here in terms of follow-up. Also, when we're looking at the follow-up of the head circumference, you know, very close following of that and characteristics through the first year of life, and the consultation as needed with other specialists. Dr. Mack, I'm going to come back to you.
Thank you. One of the things that we didn't include in this slide is that the CDC is working with states and territories to create basically a registry so that there will be tracking and follow-up for pregnant women and the infants. This information is currently something that we don't have anything defined on, but we're working together with the CDC in order to do this. So that's one of the reasons why it will be so important for providers to make sure that they're contacting us for follow-up and for testing. In summary, the Zika virus continues to circulate and cause locally transmitted diseases in the Americas. Currently, we haven't had any identified in the continental United States yet, but that's why it's extremely important to know and to get people tested. We've had some calls and requests, some calls to just let us know that they have a person that may have been had Zika, because it is a nationally notifiable condition. But the thing that we will need to know is not just whether or not this person potentially had it, but we need to get the test results if they were symptomatic, because we will need to be doing things to make sure that the disease does not become locally transmitted, which means that mosquitoes are now transmitting it to other people. In addition to looking at the travelers, there's been, in addition to some of the clinical signs where pregnancy complications that have occurred in a woman that has traveled that may not even have gotten tested is now considered to be a clinical sign where we use as criteria to then determine and do testing on that infant from a fetal loss standpoint. And the other thing that's been added is the GBS itself, the Gullian-Barré, has been added as a clinical criterion. So if a person develops it that had a travel history, or potentially a person that may be a female that their partner had a travel history and they developed Guillain-Barré with no other evidence of the cause for that Guillain-Barré, is considered to be a actual criteria that it gets included, just like the myalgia and the problems with the fever do. A substantial increase in rates of congenital microcephaly. You heard going from less than a couple of hundred, actually less than 200, to more than 4,000 babies being born in a year's time with microcephaly is pretty significant. Pregnant women in any trimester should consider postponing travel to areas of Zika virus and transmission, and there has been evidence of transmission and fetal loss in women in the United States, continental, that traveled. There was actually a meeting, and there were 2 women who actually had fetal losses, another 2 women that decided because of the, for whatever reason, one of them at least had abnormalities that we know of on the ultrasound, that decided to have spontaneous or having abortions. And then there was at least one baby, or has been at least one baby born with severe microcephaly within the United States. So this is why we're having this webinar, to make sure that you all are aware of that. Please contact ADPH for Zika testing approval before sending specimens to the lab. We don't want anything to be lost, and plus we need the information that we have to provide in order to determine what the risk is with this person. So this is your time. We wanted to give you at least 15 minutes for questions. You can actually call in, or you can send the information via the link that they have placed out there to us. So do we have any questions?
Yes, we have 2 questions. They're very similar, so I want to ask them both at the same time. Outside of Brazil, has a Zika outbreak ever been linked to microcephaly? If Zika virus has been in Asia and Africa for decades, what are your thoughts as to why a link to microcephaly wasn't detected earlier?
Okay, you want to start? Okay.
Yeah, I'll address part of that. You might be able to address the first part, but I think there's some speculation that perhaps if a disease has been endemic in Africa, especially, that maybe people are exposed very young in life, and so by the time these people reach childbearing age, they're no longer susceptible to acute Zika virus infection. And so that might be one reason, you know, that's purely theoretical, but that might be one reason that birth defects haven't been recognized. I think there's always the question, too, of just believing the numbers that you get from the developing world. You know, we sometimes probably don't know what the denominator would be in parts of Africa or parts of Asia, so it may be hard to identify increased numbers of microcephaly if those existed.
And one of the things that we specifically talked about, that you have to have a baseline, you have to know what is considered to be the normal, and that doesn't exist in some of those in the developing countries. There's no baseline. The other thing is that it is known and expected that if you have had Zika infection, that you have lifelong immunity. So if you're running around and you get infected as a child, then you know, you can't end up getting Zika infection again based on the information that we know now. So someone that's not traveling into an area or where it's been ongoing, the risk then is a whole lot less for being able to develop or wait until you're grown to develop the infection itself, okay? Now, what happened in Brazil was an introduction through whatever means, okay, of the infection within the mosquito population there when they had never had it. So that's one of the reasons why, and they also knew what their baseline was. There was a very astute OBGYN who said something's going on. You know, I normally see in a year's time maybe one woman, maybe two, and now all of a sudden I've got, you know, 6 women, something is wrong. And so once that happened, then other people started looking. It's kind of like when we have requests and calls about outbreaks. We start then calling other places to see what's going on, and that's what happened.
Most of the questions are very similar to the ones that have been asked. Does anybody from the audience have any questions?
And also remember that you can also call. Mm-hmm. So if you want to call, give us a call.
I have a question for Dr. Thomas. There have been talks about serial ultrasounds during pregnancy. What is defined and how do they, OBGYNs, manage those patients?
So thank you for the question, Tina. It's a good question. Usually what will happen, if you're talking about strictly patients who have traveled and
yes,
who've been tested. In patients who have a positive or inconclusive test, and that's included in that schematic that's part of the slides that we have. If patients test positive or inconclusive, a fetal ultrasound is recommended, again, to look for intracranial calcifications and microcephaly. And an RT-PCR amniocentesis is recommended as well. If the patient tests negative, a baseline ultrasound, fetal ultrasound, is still recommended. And again, if there are markers present for microcephaly or intracranial calcifications, an amniocentesis is performed. Okay, but this should all be done in conjunction with a maternal fetal medicine specialist. If the patient tests negative and there are no markers noted on ultrasound, the patient may return to routine prenatal care. But again, because this is such a hotbed issue with changes occurring frequently, I would recommend that decision be made, again, in consultation with a maternal fetal medicine specialist.
Okay, thank you.
I did want to do one more follow-up. Remember now that they added to the clinical criteria that if a person a pregnant woman had a travel history and may not have gone in and gotten the things done, but ends up with a fetal loss, or has a baby that has abnormalities, it's now recommended that they may not have had the initial testing, but we could even identify that they were negative or inconclusive or positive, that they be included in the testing, which is part of why we're looking at this pregnancy registry, Zika pregnancy registry for the nation.
And Dr. Matt, just to follow up on that, I think that the most important part as a pediatrician is that we have that history. We get that history at the time of delivery. You know, not every woman may be tested, but if she has traveled, I think we can go back and ask that information again at the time of delivery. You know, have you been traveling to a Zika affected area? Maybe this person has been, did not get tested. Go back to the algorithm, because the algorithm does provide information regarding the follow-up of those children.
Yes.
Okay, we have another question. Can you tell us any more about the 2 cases of Zika in Alabama and what we should expect and experience in the coming summer months?
We've actually had 3 positive cases within Alabama. They're all travel associated. What I can tell you about them is that one was in Morgan County. That was the first one. We've got one in Jefferson and one in Shelby County now, just this week announced. We are having, the CDC is being bombarded as far as with test results, so there are delays in getting results back. What we can tell you is that we expect to get more positive results because people continue to travel. The list of Zika-affected countries continues to grow. And despite the fact that we're making recommendations for pregnant women not to travel to these areas, some women are traveling or have already traveled prior to knowing that there was a problem or an issue. So we have currently approved more than 40 people for testing and received specimens that have been submitted. We know that we've got 10, at least 10 that were negative. We've got one that's inconclusive, or not inconclusive, but unspecified flavivirus, which means they had something, but we don't know which one of those flaviviruses it was. But we've got 3 that we know of right now. So what we can expect is for people, you need to be cleaning up around your homes, okay? And that means recommending going out, taking a look to see if you've got any standing water. Like if you've got pots with flowers, dump those at least once a week to make sure there's not any standing water where mosquitoes can breed, okay? Don't have any kiddie pools or dog water in the back that you don't clean out at least twice a week. Go out, empty that stuff, and make sure it's not standing. Repair screens, all of that information. The best way we can prevent having an outbreak is to prevent the mosquito bites in the first place. And the only way we're going to do that is if people practice using the repellents like we're asking them to, and if they make sure that they clean up any areas where these mosquitoes can breed. Because what we're afraid of is that although we know we have people that are positive, it's not an issue right now because it's not like we are in mosquito season. But it can become an issue. The recommendation for anyone that's positive or waiting for test results is to use mosquito repellent, either till you're determined to be negative, okay, and if you're determined to be positive for at least the first 3 weeks, okay? After that, there should not be a problem with transmitting it via a mosquito bite.
Okay. Another question, what are your thoughts on the time frame to develop an effective vaccine compared to how long it has taken to develop vaccines for the other viruses?
We do know people are working on it, but we've been told that it will probably be a couple of years. Okay, only thing I can tell you is what we're being told. People are working steadily. There is, and you all know about Dengue, Chikungunya, all of the infections. We know we've got a yellow fever virus. But Dengue, there's actually one that's being tested, that's in trials, potentially being used in a couple of countries like Brazil where there is a problem with dengue as well, but it's not available in the United States. The Zika, because it appeared to just come out of nowhere and we really just found out about it in 2015, people are working on it and they're doing their best, but it'll probably be a couple of years.
Okay.
Any other questions? We have 5 minutes, a little bit, almost 6.
Okay, I do have another question for myself. You were talking about the mosquito itself could be co-infected with different viruses. Is that correct?
There has been evidence that the mosquito can have more than one virus, but a person could be bitten by more than one mosquito. There could actually be a mosquito with dengue and a mosquito with another infection. And what we want people to understand is that we already know that we have mosquito-borne diseases circulating or within mosquitoes within Alabama. Folks don't always think about West Nile virus and Eastern equine encephalitis. These are viruses also transmitted by mosquitoes. And what we folks often don't realize is that mosquito-borne illnesses kill more people than any other disease does, mosquito-borne illnesses. So think about that. So it's not just about preventing Zika, it's about preventing getting infected by any mosquito-borne illness.
Yeah, mosquito-borne diseases are still more common than you think, especially worldwide, but even in this country, we have a little bit of local transmission of dengue that's happened on occasion, and not very often, but particularly South Florida or the Texas-Mexico border, you get a sporadic case here and there. You know, the vector is here and the environment's appropriate, and so really all you need is a human reservoir of disease. So when you have people traveling the way they do, you do see those occasionally, and probably that's what we'll see with Zika as well.
Okay.
Okay, this is last call for questions. Any additional questions? We want to thank our viewers, the audience, for watching this presentation. And as we've indicated, the information is available on the website where you can actually pull this. The on-demand video will be available usually in about 2 days, where you can actually go and watch it. And as we say at nurses and social workers, there are continuing education units that you will be able to get. For nurses, it'll be available for 1 year that you can go and watch the on-demand. For social workers, for 2 years. Remember that, and please tell any of your colleagues that did not have an opportunity to watch this video conference that the on-demand is available. Thank you.